begin the recording and turn the time over to Nikki to field your questions and maybe to share some slides. If she runs out, I have a few up my sleeve as we start to talk about the Derm path topic as well. So Nikki, the floor is yours, and ask questions as you have determined, and share us some interesting cases.
Hey, thank you so much. So, Anjali prepared some cases that she's going to show us. All of these cases are epithelial malignancies, and these are some cases that actually they might be easy when you think about it. These are we say like bread and butter of dermatopathology, but actually we just want to show how the bread and butter of pathology can be challenging and what the differential diagnosis of these cases would be and how we can work through these cases. So Angela, if you're ready, do you want to start with the first case?
Sure. I'll just start sharing the slides.
Okay.
Thank you. Give me 1 second. I'm almost done. Okay. Can everyone see the screen?
Yep.
Yes.
Okay. So I'll start with the cases now. Sorry, give me 1 second. So this would be the case first. She's a 54-year-old female who came with some lesions on her face. As you can see, it's an exophytic growth with inflammation around, some redness. There was no pain. A biopsy was taken, and this is the histological features in which you can see there is clear margins everywhere. This is the normal skin histology, and this is an low resolution. As you can see, it's going into the dermal area with some inflammation in between the epidermal and dermis. Here. Hello. This is in high resolution. Can anybody tell me what this is? So this looks, I'm
So
sorry.
let's just start with some differential diagnosis. Usually the way we work up the derm path cases, we say the first thing I ask the resident, I say, is it a proliferation or is it something another process going on? Proliferation can be benign or malignant. Can you go back to the lower power? Okay, so do we think it's a proliferation or do we think, we don't need to know what kind of proliferation it is, but is it a proliferation of any sort or are we going to have something inflammatory, for example, going on here? And you can put it in chat, but it's great if anyone wants to talk about it. Do we think we have a proliferation here? We have a neoplasia here?
Let me try to describe this thing.
Okay.
From low power, then my opinion, I think it would definitely proliferation, a neoplasm, because
Very good.
I don't see that the normal tissue have this appearance, and
Very good.
and it try it it try to infiltrate the dermis with the uh inflammation, maybe lymphocytic infiltrate. And I think that would be a malignant neoplasm from this low power.
Very good job. And that was my second question. Now we think it's a neoplasm. Do we think it's benign or malignant? And something to remember, in each organ, malignancy and benign, they can have very different features. There are some areas, there are some neoplasms, even one mitosis is going to consider as an atypical malignant process, but there are some components that they have more mitosis. And one of the things is in the skin, actually, we allow a little bit more for more mitosis. The reason for that is a very proliferative organ. It's the first line of defense. So because of that, any organ that needs to proliferate a lot, but what happens when we proliferate? We have to have mitosis before proliferation. But this is an abnormal proliferation, which we call it neoplasia. And if you go to the next slide, we can see it has some atypical features. We're having pleomorphism. Pleomorphism means the size of the cells are different from each other. You're having prominent nucleoli, you're having irregular nuclear border, and all of these things are signs that we're having some sort of malignancy going on. So one of the features that we're seeing here is the cells are not having as much of cytoplasm as we usually want them to have. They're kind of a little more maybe a spindle-shaped cells. And based on this, what differential diagnosis would you have for a case like that? Okay, Angela, do you want to go for the differential diagnosis?
I can.
Yes.
These are the differential diagnoses. It could be a spindle cell or desmoplastic melanoma, peripheral nerve sheath tumor, angiosarcoma, or leiomyosarcoma. It could be a epithelial tumor or a dermal tumor. So how we differentiate between whether it's epithelial or dermal will be deeper and it will be cytokeratin negative, but the epithelial will be cytokeratin positive. So in this tumor, this tumor had P63 and P40 positive. So anybody want to give it a go, which one it is? Dr. Nikki, should I just tell the answer?
Yes, go for the answer.
So the answer is spindle cell sarcoma, carcinoma.
Spindle squamous cell carcinoma. So in general, whenever you're having a spindle cell proliferation in the skin, there are a few differential diagnoses, and almost always these are the same differential diagnosis you're going to have it. One of them is squamous cell carcinoma. Squamous cell carcinoma in general, it doesn't have a spindle cell morphology, but sometimes they can have a spindle cell morphology. And Angela is going to talk about the risk factors for that, in what conditions we're having those. But one of the main thing is because whenever we're having this spindle cell morphology, you have less keratinization. Because of that, we're thinking less about a squamous cell carcinoma. Something I tell the residents, if you see something pink in the skin, is a malignancy pink in the skin, think about a squamous cell carcinoma. If you see a blue malignancy in the skin, mostly think about basal cell carcinoma, but of course we have other differential. The problem with the spindle cell squamous cell carcinoma is it's not that pink anymore. So you have a spindle cell squamous carcinoma, which is going to have keratin positivity. The other one is going to be desmoplastic melanoma. For desmoplastic melanoma, you're not all the time you're going to have the epidermal changes that usually you want to see in the melanoma. If you have the epidermal changes, great. It's going to make the diagnosis easy, but sometimes you don't have that. So it's going to be based on the immunohistochemistry. The problem with that is many people, most of you probably experienced that, we order melanate, for example, HMB45. Desmoplastic melanoma is actually negative for those markers. It's positive for the nuclear marker or S100. So if you're within the differential diagnosis of desmoplastic melanoma, just don't go for melanate HMB45. It's going to be negative and it's not going to help you because it's still desmoplastic melanoma. It's just the wrong stain. The next one are peripheral nerve sheath tumor. This is a diagnosis you have that you have to have two conditions to diagnose it. Either patient is having neurofibromatosis or the patient is having these lesion in association with a big nerve most of the time. So because of that, it's a little more rare to see it in the skin, especially if the patient is not having neurofibromatosis. And these are the ones, actually S100, it's a nerve sheath tumor, but S100 can be negative. So basically they're going to be patchy positive. Again, the condition is usually different in these patients. Angiosarcomas, usually they're having more of, they're having vascular marker positivity, but there are conditions that when they're poorly differentiated, you don't see a lot of like vessel formation, and still they're going to retain the vascular marker expression. And leiomyosarcoma is one of the ones which is the main ones that you want to rule out, and it's going to have the smooth muscle differentiation for these ones. So as Angela said, this is a spindle cell squamous cell carcinoma. This is a very rare finding, but it's not rare that you never see. You're going to see it in your practice, especially if you're having a good amount of derm path synapse. Okay, let's go to the next one.
So it's a very rare variant of squamous cell carcinoma, and the risk factors include ionizing radiation, prolonged sun exposure, burns, or in immunocompromised state. Like the microscopic features, as Dr. Nikki described, this was an excision biopsy with well demarcated borders with negative margins. There were sheets of spindle cells with hypochromatic nuclei, minimum keratinization. It's not as pink as it should be in squamous cell. Inflammatory response near dermis is present, and immunochemistry is required for diagnosis. So it's P40 and P63 positive. The management includes wide local excision for the body and most micrographic surgery for head and neck lesions or recurrent tumors. Prognosis is worse than conventional squamous cell carcinoma. The local recurrence rate is near about 20 to 30%, while conventional is 5 to 10%. 5-year survival rate is low as well at 60 to 70%, while conventional squamous cell is more than 90%.
Okay, do we have any question about this one before we go to case 2? Okay, I love it. No question. Let's go to case 2.
Case 2. There are two cases here. One, there is exophytic growth on a person's heel. One is on the finger distal phalanx. I'll go to the next one. Same as well. This is a gross description of exophytic growth near the nail bed, left ring finger. This is the microscopy in low resolution. As you can see, it has two components, one exophytic growth and one endophytic growth. The exophytic growth is well circumcised, and the endophytic growth has pushing borders here. I'm going to go into the low resolution now. These are the cells in 40x high resolution. Anybody guess any guesses? These are polygonal cells. Should I go to the diagnosis, Dr. Nikki?
Go back to the previous one, please. Yeah, I think we have someone who wants to give the differential. Atrial melanoma, it's a good thought, But if we go to let's go to the higher power. Okay, if you go to the higher power, you see there are more of the cells are having more cytoplasm. The cells which are having the biggest cytoplasm. Okay, um, very good job. We're having someone saying it looks like SCC. Very true. It looks like SCC because they have a lot of, we are having a proliferation of epidermis. As Angela said, there are polyclonal cells. We have a lot of cytoplasm, and that's the reason it's pink. Remember, the nuclei is blue, the cytoplasm is pink. If you're having a proliferation which has more cytoplasm compared to the nuclei, you're having a pink proliferation, but it doesn't have a lot of atypia. It's interesting because it's a very big proliferation. It's just kind of the borders are big, but usually if you're having a squamous cell carcinoma, you would want to have more atypia. Very good job. So I think we got the right answer. So let's go. Angela, do you want to go to the answer?
Sorry. So these are the differential diagnosis. It could be a verrucous squamous cell carcinoma or a conventional squamous cell carcinoma. Could be warts. It could be a giant condyloma, and it could be a scar-associated squamous cell carcinoma.
There is one more thing that it could be sometimes especially if the surface is ulcered, it could be in the differential diagnosis, and it would be keratoconoma. Keratoconoma actually in the cases that kind of in the proliferative phase, it could be a little similar in the configuration, especially if, like, for example, we're having the verrucous squamous cell carcinoma, it's ulcerated and we're not having that exophilic component of it very well.
So in this slide, the cells were well differentiated with pushing borders, and there was minimal atypia, as Dr. Nikki said. With conventional SSC, there will be keratin pearls and atypia will be more prominent. How to differentiate whether it's what? It's usually histologically similar, but there is no dermal invasion, and it will be HPV 6 and 11 positive. That's why it's important to do a deep tissue collection. Otherwise, if you do a superficial tissue collection, you will get confused between the verrucous squamous cell carcinoma or the warts, because the superficial layer is histologically similar. Same thing with giant condyloma. It is histologically similar, but it occurs in anogenital region, whereas this occurs in other parts of the body like hands and feet and things like that. Oh, and there is one in scar-associated squamous cell carcinoma, which is also similar histologically, but the clinical history is what differentiates it. So some information about it. It's a low-grade subtype of squamous cell of skin and oral cavity. It's associated with alcohol consumption, areca nut chewing, and tobacco consumption. Most cases are on the feet. Caution should be taken while taking a sample, as superficial biopsy can be mistaken for benign squamous lesions like wart. Definitive diagnosis requires deep incisional or excision of tumor. The microscopic features include it's a well-differentiated squamous proliferation with exophytic and endophytic component. The endophytic component contains blunt projections of deep bulbous processes with pushing borders. Large polygonal cells are present with abundant pink cytoplasm and large nuclei with minimal atypia. There could be lymphocytic inflammation at tumor stromal interface. Management. It's the same as the previous one. It's a wide local excision with clear margin. Radiotherapy is contraindicated as it may lead to transformation into poorly differentiated conventional squamous cell carcinoma. It is excellent prognosis. It's a slow-growing tumor, locally aggressive, and it rarely metastasizes. Recurrence occur in poorly excised tumors.
Okay, if you think about it, it's a verrucous type of a squamous cell carcinoma. It's a very hard entity to make the diagnosis because basically all you're making your diagnosis based off is going to be the pushing borders. You don't see any definitive invasion. You're not seeing any definitive atypia. Actually, if you're having atypia, it's against it. So basically, all you're saying is if it has pushing border or not. And many of you that you have seen these big condylomas, you know, all of them, they seem they have pushing border. It's just like because it's a tangential cut, they're large. So the diagnosis of this is not easy. The good news about it is just the fact that these are very indolent malignancies are not going to act as those crazy big squamous cell carcinomas, and that's one of the reasons we don't like to give this radiation, because radiation is going to increase other malignancies, sarcomas, or other like squamous cell carcinomas arising at the site. So if something is not acting too bad, you don't want to push it too hard to make them act crazy. And for these cases, usually a complete excision is going to be enough for the patient. There is a controversial, it's a controversy about if they're HPV associated or not. It's in a skin dermatopathologists, we usually think they are actually HPV associated, but if you talk to gyne pathologist, Dr. Hassel can say more about it. What I hear mostly, oh, these are not HPV associated. Again, some of them are, some of them are not. If you go to the WHO book, which is like the Bible of the pathology for us, they say actually most of them that you can see in the immunosuppressed patients are HPV associated. You can do P16 on these. But P16, I don't, in general, I have seen that it's not helping me that much. If I have these cases, I may send them for each the low risk and high risk. The problem is if it comes back as negative, it's not going to do you anything. If it's coming back as positive, it's not going to help you. So most of this is going to be if you have a good sample, if you can see the borders, you can see the bottom of the lesion well. Once you see that, if you see, oh, it's pushing is a little too much, um, like pushing border for this lesion, and then you can call it. In my practice, it's most of the time it's more goes as a suggestion, consistent. I think I never had that I can go 100% for it, and the clinicians are usually really good about it. They say like you can do a conservative excision, they don't need to do lymph node or anything like that. They just need to go and take the whole lesion back, and hopefully we won't have recurrence, and these are having a very low rate of metastasis. But again, these are very hard diagnoses to make. Nothing helps you. No atypia, like no invasion. It's basically going to be based on the just a few morphologic cues that you're having about these cases. Any questions?
Nikki, I'll just make one comment here that sometimes in the anogenital area, these lesions and the giant condylomata can have entrapped bacteria and so forth that can incite an inflammatory reaction that makes the inguinal nodes appear hot on scanning or enlarged clinically. And that can potentially lead to kind of overreaction to the severity of the tumor, thinking that it's a stage 2 or beyond. So bearing in mind that process can occur not due to metastasis is very important in this situation where you have a bulky, complex squamous proliferation that can entrap bacteria and so forth. And that's one area where fine needle aspiration of the lymph nodes and so forth can be very useful if they're concerned about that as well.
Yes, exactly. Anytime the skin is inflamed, the lymph nodes they like to pop up. It's like something we see in hidradenitis. Most of the time, when I see the skin excisions, because it's hidradenitis is a condition that is very, very scarring. It's painful for the patient. Again, benign. The surgeon they're actually taking out the lymph nodes, and they're very big lymph nodes. Sometimes I just get scared myself. I'm like, oh, this patient is having lymphoma at the same time, so I send it to our hempath colleagues to make sure that they're reactive or not missing anything. But as Dr. Hassel said, anytime you're having a skin like reactive changes in the skin, the lymph nodes are going to have a good amount of reaction to it. They don't like it, so they're going to just get enlarged and juicy. Um, very good job. Okay, if there is no question, we can go to the next case.
I have one
Yes.
question. I think it would be more difficult if we are dealing with a small biopsy from that kind of this disease. But my question is, does the clinician usually take a small biopsy from this kind of tumor?
Yes, it's so most of the lesion when they take it out, there are either two things they're thinking about. Either they're thinking about condyloma, they want to take it out. So for condyloma, they try to take the most of, again, they don't go for the margin, but they try to take the entire thing. Or if they're thinking about a squamous cell carcinoma, that's the type that sometimes they come with the like a smaller biopsies. There is no way to say in a smaller biopsies. And it's if they are thinking about again, we don't have any atypia. Even the architecture is not something that you can go based on the small excisions. You have to see the entire tumor. One of the things that's going to help you, if you in a small biopsy, if you're not seeing atypia, you see a lot of proliferation, not atypia, then you're not going to think about squamous cell carcinoma and like the conventional squamous cell carcinoma. You're going to think about verrucous carcinoma or verrucous form squamous cell carcinoma, and that's going to help them in some management. They need to go back and take the whole thing out anyways, but they don't need to go after the lymph nodes. But no way to say it in their small biopsies, and don't overcommit yourself. That's something I learned. Sometimes it takes a phone call to call them and say what's going on, what you're seeing, um, but no way to say it in the small biopsy. Okay, let's go back. Let's go to the next case.
So a 60-year-old male presented to a clinic with large exophytic growth on his face. This was the excision biopsy taken in low power. And this is the high power resolution. As you can see, there are large clear cells with clear margins and pleomorphic nuclei. Should I go to the differential diagnosis?
Now let's see if anyone can have some differential diagnosis for this case. Sebaceous carcinoma is a very good differential diagnosis. Liposarcoma, let's go to the low power. Okay, so this is something, if we are having, and I'm not saying it as an impossible thing, and you never say never in pathologies, everyone knows. But if usually liposarcoma is coming from the lipomatous tumor, so it should come from, even if we have it in the skin, which is first of all, if we have it in the skin, usually we don't call it liposarcoma, we call it atypical lipomatous tumor. That's something to remember. If you're having, if like a malignant lipomatous tumor is in the if it's not in the visceral organ, like it's not retroperitoneal, we don't use the liposarcoma terminology anymore. We call them atypical lipomatous tumor. But they usually should come from where we have fat. So this is coming somewhere that we think is coming around the epidermis or the superficial layer of the dermis. So even though it's a very good thought, especially the high power picture it looked like lipoblast, but the location and the scenario doesn't look good for it. Let me see. The sebaceous carcinoma is a very good thought because they have kind of the clear cytoplasm most of the time, and we're going to talk about it. Anything else that we think about the possibility of it? What else has kind of more clear cytoplasm or halo or has the potential to have it in the skin? There are a couple more things that whenever want to think about it. Melanocytes. Melanocytes, they can kind of have a little bit of halo. BCC actually can have some clear cytoplasm. In some cases, you can have a little bit of clear cytoplasm around it. But if you, Angela, can you go to the higher power? So for BCC, most of the time when you're having some clear cytoplasm or white space, you're having it around the nest because that's a clefting artifact. And I'm going to tell you why we're having clefting artifact or these halos in two conditions. One is melanocyte, that they have a halo. The reason for that is, again, remember, whenever we put the tissue in formalin, the tissue is going to shrink. If they don't have very good adhesion to the neighboring cells, then when they shrink, you can see kind of these white spaces. Melanocytes, they don't have desmosomes. So because of that, when they shrink, you kind of can see these white spaces, these empty spaces, that anything is empty on the slide is going to be white. And then basal cell carcinoma, they don't have full desmosomes. They have hemidesmosomes because they're at the basal layer. Normal keratinocytes, they have full desmosomes. Basal cells, they're having hemidesmosomes. Because of that, the adhesion is not as firm as a squamous cell carcinoma. So whenever you put it in formalin, when the tissue is shrinking, they're going to have this clefting artifact. So those ones, let's see, adenoid cystic carcinoma. It's a very good thought because we're kind of having it seems like a cystic structures, but remember, what you're seeing in these cells, this is very high power, by the way. It's like a single cell. Adenoid cystic, you're having those empty spaces, and that's a very good thought because you're having these white spaces, but they're going to have more of the glandular component to it. But these are these white spaces you're seeing here, these are single cells. This is not a glandular component. That's the reason I said this is very high power. This is probably something around 40x, and that's the reason you're seeing these white spaces. They look very large, but these are single cells. All of these are very good thoughts. There are a couple other differential diagnoses, and Angela, you can go to the differential diagnosis of it, the full list.
Sorry. So one of the differential is clear cell squamous cell carcinoma. It could be extra-mammary Paget's disease, clear cell hydranoma, sebaceous carcinoma, or it could be a balloon cell melanoma. There's also a possibility of renal cell carcinoma, metastasis to the skin. I don't know why it's not included in the slide.
I think it's in the bottom of the slide. That's the reason it's not showing it. Yeah, that's okay. So this is so for these ones, there are some clues that can help you, but also some of the stains are going to help a lot. Whenever you're having a squamous cell carcinoma, Angela is going to talk more about the histology that you're having keratinization in most of these cases. but you're having the markers which are going to be positive, like P63, CK56. But the problem is in some of the other ones, these markers can be positive. Extramammary pathology is one of the things that has clear cell. Kind of not clear cell, but the cytoplasm is lighter. It's very light bluish. They're usually within the epidermis, but sometimes they can have the invasion. In those cases, we can have CK7 positivity in PAS. In general, CK7 positivity is for skin and neck cell. It's not going to be just for the normal epidermis. The other thing is a clear cell hydroadenoma. Hydroadenoma is a skin and neck cell proliferation neoplasm. Clear cell hydroadenoma is benign. For squamous cell carcinoma, you usually have malignancy. However, in very rare cases, you can have clear cell hydroadenocarcinoma. And whenever you have those things, it's just those are headache to differentiate them with clear cell squamous cell carcinoma. I had one case of it last year, and it was in a patient with again, these are usually not, if you have a clear cell hydroadenocarcinoma, these are usually not normal patients. These are having very like they're very immunosuppressed, or they're very sick patients, or things like that. Again, it's coming from the skin adnexa. So you're having CK7 positivity, GATA3 can be positive in a skin adnexa. What's the other organ which is GATA3 positive? Anyone knows? Breast is GATA3 positive, right? So a skin adnexa and breast, actually, they're coming from the same line of differentiation during the development. Because of that, they have a lot of CK7 is also positive in the breast. So because of that, they have a lot of overlap with each other. Sometimes when we have, sorry. Yes, that's actually a very good job. Urtilia is like that too. The other one is CEA is positive. CEA can be very rarely positive in a squamous cell carcinoma, but that's another positivity. Again, clear cell hydroadenoma or hydroadenocarcinoma, they're very rare. If it's a hydroadenoma, you should not have ATPI, that you have it in a squamous cell carcinoma. If it's a clear cell hydroadenocarcinoma, that's the moment you think, oh, why did I choose this specialty? There can be very confusing. Sebaceous carcinoma, that I think that was one of the first differential diagnoses we had, is a great thought. It's the first thing you need to think about it. The difference of it is going to be sebaceous carcinoma. Whenever you're having this clear cytoplasm, they're kind of a little lobulated. It seems like, oh, they're tiny, like a honeycomb. They look within the single cells, and not important differentiated one, but in most of the cases, if you go to the corner of the tissue, you can see some still remaining sebaceous, normal sebaceous glands. But these are very good ones. One of the reasons you need to think about sebaceous carcinoma, because if it's in the younger patient, they can be associated with Lynch syndrome. So sebaceous carcinoma is an important carcinoma to distinct from clear cell squamous cell carcinoma. The stains that Angelique put are a perfect stain that you can use it. Usually in my normal practice, I do adipofillin and androgen receptor. There are some articles that they're talking about PRAME positivity, but PRAME can be almost positive in anything high grade. So because of that, I don't think it's something that you need to count on it. And adipofillin and androgen receptor are going to be the ones you're going to think about it. One thing to remember, if you're having sebaceous carcinoma in a young patient, check for the methylation profile, because these are at high risk of Lynch syndrome, and you can save someone's life. Balloons and melanoma, these are the ones that they have more of the grayish cytoplasm in general, and they are going to be positive for monocytic markers. So what I usually tell people whenever you have these cases, do CK7, do one keratin, like P63, P40, do one of the like sebaceous markers. I really like androgen receptor myself, and do one monocytic marker. The metastatic renal clear cell carcinoma, usually you have the history. It's very rare to just come as a first sign as the like a skin metastatic lesion. For those ones, you just need to check the chart to know about it. The other thing is they're very vascular tumors, but they can go to the skin. I saw that a lot. They usually go to the scalp, the skin, whenever they're having metastasis. Any question about the differential diagnosis? Okay, perfect. Let's go to the next one.
So squamous cell carcinoma is the second most common type of skin cancer. This clear cell variety is extremely rare with only a few documented cases. In this case, it was an excision biopsy with round to polygonal cells with distinct border, abundant clear cytoplasm, hypochromatic nuclei, and pleomorphism. Management is the same, a wide local excision with clear margins, a Mohs excision therapy for head and neck lesions, and radiotherapy for recurrent cases. This is the last slide, Dr. Nikki.
Okay, great. For these cases, again, it's just going the criteria for if they're high grade or things like that. These are just whenever we're having these like atypical or weird shapes of a squamous cell carcinoma, they're a little more aggressive, but the other criteria is going to be the same criteria that we're using if we're having perineural invasion. If the perineural invasion is more than 0.1 millimeter in caliber. And one of the important things that actually is not in the CAP checklist summary, but it's very important for prognostic is if you're having many perineural invasion. And for anyone who is going to sign out in the future, that's something I really recommend you that if you see extensive perineural invasion, just don't go just for the size of it. Just say extensive perineural invasion. And that's going to help a lot with the management. Again, they don't want to radiate if they don't have to. That's going to give rise to other sort of malignancies. They only want to do it for high-grade lesions. Anyone has question about this one? And I think that was our last case.
So, Nikki, we see clear cell changes in squamous cells in other organs as well, usually not quite as pronounced and pleomorphic as this one, but it is a feature where you have sharp cytoplasmic borders and fairly clear cytoplasm that you can see, in cervical cancers and squamous differentiation in endometrial tumors or lung tumors that have squamous origin. So it's good to be aware of this propensity of squamous cells to occasionally present as apparently clear cells, and in this case with the nuclei pushed to the side, resembling renal tumors.
Yes, it can and sometimes you know it better than me, Dr. Hassel. It's like the artifact that if the tissue was not fixed well or something like that, we can also have this clear cell artifact in the tissue, but usually in those cases it's like not as bad as this one. But again, in the skin, the differential I think is a little more limited. I'm thinking about like other organs, they would even have more differential diagnosis for these cases, which can make it even more challenging. Okay, if no one has a question, I'm going to ask a question myself. So, and that's the rule. You always want to ask the question, so many questions, so they don't have time to ask you questions. So, we had the spindle cell type of the squamous cell carcinoma. The other name of it, like they call it sarcomatoid, the spindle cell, sarcomatoid squamous cell carcinoma. But what's the difference of this one and a squamous cell carcinoma with sarcomatoid differentiation or sarcoma differentiation? Does anyone know? I'm asking this question because I had for the first time, I had a real one a few weeks ago. So the difference of it is for these ones, you're having a spindle cell differentiation because the spindle cell differentiation looks like sarcoma. We call it sarcomatoid or spindle cell squamous cell carcinoma. But for the sarcoma differentiation, they actually have a sarcoma component to it. So you can see these ones, if they're very high grade, and those are having bad prognosis, you can have cartilage in it. You can have rhabdomyosarcoma in it. And it's so funny because it's in the book and I read about it a lot. And I had for the first time, I saw the case last week. Actually, I had a squamous cell carcinoma with rhabdomyosarcoma in it. So that's very rare. It's not going to be something you're going to see every day. But remember, if you have those cases, they have a different name. They call it sarcoma differentiation. They're in different category in WHO book. But for these normal, if you see sarcomatoid, squamous cell carcinoma, or spindle cell squamous cell carcinoma, they're basically in the same category that you're just having this kind of proliferation. There is spindle cell proliferation in those cases. Any question? If there is no question, I think we're done.
I have a quick question. And sorry, I missed a little bit of it. But you were talking about the PRAME IHC, and that's new to me. Can you talk a little bit about that and how it's used?
Yes, so PRAME, in general, we're using it for melanocytic lesion. But if it was 100%, they didn't need the dermatopathologist anymore. So it has several clones. A couple of the clones, one of them is better than the other one. So there are some rules. It's not about just positive or negative. It's a 1+, 2+, 3+. It's about the percentage of how many of the cells are positive. So if it's helping with melanocytic lesion, but it's not going to be 100%. One of the worst thing about it is just it's negative for desmoplastic melanoma. And that's one of the things we usually need help with it. So for me, whenever I'm between severely atypical dysplastic nevus and melanoma, and if I see it's PRAME positive, then I'm going to go and call it melanoma. That's going to help me. But it's not going to be positive in all of the melanomas, and not in everything which PRAME is positive is going to be melanoma. It's helpful I think it's more helpful in the borderline lesion when you're thinking about it. The other thing is what they say is like basically if you go on a high power 40x and you see more than 10 cells which are positive for PRAME, you can consider it as a positive marker. But if you're having a scatter cell, especially if you're seeing like a head and neck area or the hands of the elderly patients that they have a lot of solar elastocytes and sun damage, you can have background PRAME positivity in those cases. Again, for melanocytic lesion, when you're between severe and melanoma, I think it's going to be a very good marker, but it's not a 100% marker. My routine is for all of the melanocytic lesion. If I'm ordering SACs, I also order PRAME, both of them together. And sometimes I'm just like, why did I do that? It's like it's positive, and now I'm like, what should I do with this one? One of the things is in the pediatric melanocytic lesion, it's going to be positive. It doesn't mean malignancy or anything like that. In anything, I do it because I do soft tissue. I started ordering it on my soft tissue lesions to see how it's reacting. I just noticed it's anything high grade, it's anything proliferative is going to be positive. So now I'm thinking for non-melanocytic lesion, I'm using it as a proliferative index right now, but you can see it positive in angiosarcoma, which is something actually I liked it because for angiosarcoma, you don't have any marker. So I do PRAME and I see when it's positive, I'm between like borderline of some intermediate ones. I'm like, oh, it's PRAME positive, so I'm leaning more toward, for example, angiosarcoma. But the main use of it is in the melanocytic lesion. Again, if you're having an intradermal nevus, don't order it. It's going to come back positive sometimes, and it's going to be, oh, what should I do with it right now? But if it's diffusely positive, if it's strongly positive, especially in the borderline lesion, it's a very good marker. Almost in all of melanomas, if it's not desmoplastic, I see positivity of it.
Oh, interesting. Yeah,
But
that's
it
great.
can
Thank
be,
you.
yeah, it's good for melanomas, I think. But the problem is it can be positive in non-melanomas.
Yeah, great. Thank you so much.
Yeah, of course. And if you order it, it's better to order it red. I
Ah,
don't like anything brown for the skin for melanocytic lesions because it's a nuclear stain also.
oh, okay. That makes sense.
Yeah.
Thank you.
Just to clarify for some of the students there that with immunohistochemical stains, at least in our systems, you can use either a brown chromogen or a red chromogen. And as we talk about the melanocytic lesions, that's where the brown of the melanocytes can interfere with the usual brown chromogen that we use for most immunoperoxidase. We'll get into more melanocytic stuff next in our next mentoring session. Today was more on the squamous lesions. And we didn't cover very many of the common stuff, the common things like actinic keratoses and seborrheic keratoses and so forth that you're going to see. But these were some challenging cases to think about on the margins of some of the differential diagnoses we deal with.
Melanocytic lesions are more interesting in my opinion, but of course I'm biased.
They definitely are what make you a very valuable asset to the team.
It's job security, so I like it.
Yeah. So any other questions before we wrap up? So I have one question, and that is, which of you, one or two, would like to do some case presentation for our next session in 2 weeks? You can either put that in the chat or email me or Felicity or Nikki, and we will work with you to find a case that you can present and discuss in our next mentoring session. I'm going to guess that, Anjali, you learned the most from this presentation of anyone here. Is that right?
Yes. I would like to do the next session too if
You'd like to do another case. Okay. Well, we want to share the wealth a little bit. So maybe if others would like to volunteer, please don't hesitate that as well. Well, thank you very much, Nikki, and everyone for participating today. And we will see you again in a couple of weeks. We'll post the recording of this if you want to go back and see that later on as well.
Thank you.
Thanks, everybody.
Thank you.
Great job,
Thank
Anjali.
you.